patients' families would be pushing food on them.
Yeah.
And so they'd
saboteurs.
Yeah,
It's
exactly.
a real thing.
It's
a real
right?
thing.
Yeah. And I mean, and a lot of times food is the love language, right? And so and if you don't eat, they ask like, do you not like it? And so it becomes kind of a social aspect as well. And so that was a big, when we had our social support group meeting for around Thanksgiving, Christmas, a lot of us talking about how to deal with food pushers at holidays.
Hi, everybody, and welcome to EndoCast. I'm your host, Leslie Bishop, and this is episode 31 with our physician guest, Dr. Christopher Chapman of Rush University Medical Center, alongside his nurse practitioner, Sarah Kosinski. EndoCast is a GI-focused podcast for clinicians, by clinicians, presented to you by Boston Scientific. Together, we'll take a closer look at the data, techniques, and insights of endoscopy that matter most to listeners like you.
Dr. Chapman and Sarah, welcome to EndoCast.
Thank you. Thank you for having us.
I'm really excited about this topic. And before we get started, I'd love you guys just to introduce yourselves with your background. You can start, Dr. Chapman.
Sure. So my name is Christopher Chapman. I'm an interventional gastroenterologist at Rush University Medical Center. I did my medical at Johns Hopkins University and then did my residency, chief residency, GI fellowship, and advanced endoscopy fellowship, all at the University of Chicago.
Oh, wow.
I was there for a long time and then was faculty for 6 or 7 years there before moving to Rush University. I do interventional endoscopy, but my specialty is in EndoBariatrics and ESG balloons and revision procedures.
So what % of your business now is dedicated to weight loss?
It depends. In clinic, it's about 90%. So I see a lot of patients who are interested in weight loss in my clinic, but the conversion to procedures is probably about 20%. And so 80% of my endoscopic practice is still EUS, ERCP, colonoscopy with EMR, and other resections in the upper GI tract.
All right, and Sarah.
I'm Sarah Kosinski. I'm a nurse practitioner, and I got my doctorate in nursing practice from Rush University. And then I started working with Dr. Chapman at University of Chicago as a new grad, and then been working with him for about 6 years now.
Very, very fun years.
Yeah, those are the best years.
Well, we worked together for a while at University of Chicago,
Yeah.
and then we both left.
Yeah.
And I went to Rush, and then I said, I need to get Sarah back. And so she was this close to going back to University of Chicago,
Yeah.
and I was able to pluck her back.
You said, Sarah,
back to me.
no, you have to come here.
Well, you'll hear from this podcast that she plays such an instrumental role in our program that I had happen.
Yes.
Yeah.
So I want to hear what got you interested in going into weight loss.
Well, I first got interested in weight loss because I fell in love with the suturing device. So I had my first exposure when I was an interventional fellow in 2015, and I actually remember doing our first suturing case. It was a stent fixation for someone that had a perforation. So we placed a stent and we used the suturing device to fixate the stent. And I remember being in awe about the mechanics, the gears, the ability to do suturing from a distance, and the handle and the device. And I fell in love with that device. And it was such a profound moment because it was a new tool and a new toy, and I like new toys, and they're shiny, and that really got me interested. And then you start thinking about what are all the other applications, and so there's stent fixation, fistula closure, and then when the opportunity for EndoBariatrics or weight loss procedures, you think, wow, this is a procedure that could help millions of people, and we know that only 1% to 2% want to get bariatric surgery, but the main drawback is risk of complications, or they don't like the cutting aspect of it. And so if we could do this all minimally invasively, that could be a game changer.
And when did that start for you?
That started in my advanced endoscopy fellowship because I actually flew to New York to watch a friend and colleague, Reem Shariah, do a couple procedures. Then I begged and pleaded to do a overstitch training course. And then so we started that journey that way. And I also went to some courses. I went to Miami to see Chris Thompson's course, actually, as an attendee. Then I got a travel grant to go to Europe, and I spent a month there traveling to different places that were doing ESG in Europe, and took all that knowledge to then come back and start a practice here.
So when were you in fellowship? Like, how long ago was that?
That was 2016.
Okay, so quite a while.
Yeah, quite a while. And then did my first ESG procedure in 2017. So about 6 months after starting assistant professor at University of Chicago, I did my first ESG.
All right. You want to explain to everybody exactly what the ESG procedure is?
Yeah, so the ESG procedure is a endoscopic procedure, meaning we use a thin scope with a camera on it to go down through the mouth and put in full thickness sutures to reduce the size, volume, and length of the stomach down to about the size of a banana. So it's about a 60
Oh, wow.
Yeah, I know, it's a good visual, right? You can see, everyone knows what a banana looks like for reference. It's about a 60 to 70% stomach reduction, and that reduction ends up leading to increased satiety, feeling full faster, and gastroparesis, delayed gastric emptying. That hopefully helps induce weight loss as well. And so it's nice because it's outpatient. It takes about an hour to do. So no cuts, no scars.
Yeah. So if they were going to choose a surgery, what would be the recovery for that?
Well, a lot of times it requires inpatient hospitalization for a couple days. Our surgeons are very good, and surgeons definitely have a role in the treatment of obesity, and bariatric surgery can be the most effective option. But I do think the recovery and the downtime, getting back to your life, is definitely going to be shorter with endoscopy, and the risk of complications are lower. So we have about a 2 to 3% serious adverse event rate, and that's probably about half the risk.
About how much weight loss can somebody expect to lose from an ESG procedure?
It just is a slower weight loss. So it ends up being about 1 to 2 pounds a week or 4 to 8 pounds a month. And it's about that expectation, because most of the weight loss comes in the first 3 to 6 months, and then you kind of get more in a maintenance phase. But you can still continue to lose. It comes back to the patient driving factors.
Are you calling 1 to 2 pounds of weight loss a week slow? Because that's
no.
that's after a year, they're still potentially losing 1 to 2 pounds a week.
Yeah, if you do healthy natural weight loss, it's about 1 to 2 pounds a week is kind of what you're shooting for. And for a lot of people, they've been struggling with weight, or they have a lot of emotion tied to their weight, that a lot of times it does seem kind of slow to them. And you know, we live in a society where people want things yesterday. The whole drive-through economy is based on getting things as fast as possible, right? And so I think people do want it as soon as possible, and that's a part of our job, and Sarah's job, is to set appropriate expectations about what is the rate of weight loss to be expected. And you know, Sarah and I, we still do a lot of GLP-1 medications because it's a big part of our practice and in obesity medicine care in 2025. And sometimes you lose weight too fast, you lose lean muscle, and that can actually cause to have facial muscle wasting, and you don't look as healthy as you think you do, even though you're losing weight.
The face gives it away.
It does, yeah.
It's bad.
I know. We've had to decrease people's medication doses purely for that. And Sarah, I mean, you've had that conversation, how do they take that, you know?
Yeah, they don't take it well.
When you say we have to slow this down because you're looking like an old man.
Yes, they're like, oh no, I'm fine. We have to have a heart-to-heart and really go through, like, we really need to go down on this. Yeah.
They're like, I like my skinny jeans. I don't care that I look 10 years older. They're fine.
For the most part, until, like, I don't know, you just kind of have to, like, make them realize that, right? It feels like they're so focused on the number or the size of the jeans than the actual, like, just take a look in the mirror and see what's really going on. And we need to get some more, like, resistance training and protein.
But that's the role of our multidisciplinary team, is to actually make sure patients are getting enough protein, that they're doing the strength-based exercising, because a lot of those medications will result in meal skipping, and as a result, you're not getting enough protein that you really need. And honestly, part of our multidisciplinary team is to help say, when you say take more protein, what does that mean? How do you execute that? And it's a big problem, because anyone could say take more protein, but that's not really helpful. And how much protein, and how do you actually get that protein is a big role for our dietitian and our team to do that.
Okay, can you talk more about the multidisciplinary team? Who all, this is like, I don't know, when I think of endoscopy, you think of a procedure and then they go home, and this is not like that. This is a very multifaceted, so can you talk about that?
Right. In endoscopy, we tend to focus so much on the technical aspects of the procedure. What kind of suture pattern are you going to do? Where do you start the sutures? How many sutures you put in? But in reality, what leads to good outcomes and safety is really the pre and post care, and patient selection, setting appropriate expectations, and then making sure you have adequate follow-up with not only yourself, but also our dietitians and our psychologists. And so every patient that comes and sees Sarah and I, we make sure they see a psychologist and dietitian as part of that evaluation. They kind of have to be cleared before we can move forward for a procedure. And we looked at our data, and all the patients we sent to psychologists, 75% of them have had prior history of psychiatric disease.
Wow.
That's self-reported, and about 20 to 25% either have emotional eating or binge eating. So if you don't address those things before you do a procedure, you're going to set yourself up for having complications or weight regain issues.
How do you address the binge eating? That seems very difficult if you haven't done the procedure.
Well, it begins with behavior change and acknowledging and meeting with our psychologist. So it's something that our psychologists will actually work with them over a period of time. So we've had patients go months and months working with them to make sure they have addressed their maladaptive eating behaviors, come up with alternatives to when they feel these type of stressors in their life, to make sure that they don't resort to food as the solution to those problems when they arise.
Yeah, this GI psychologist does a lot of cognitive behavioral therapy options for them, and then as well as like there's other medications too, like Vyvanse and other things that are used for binge eating disorders. So.
And that starts before the procedure.
Correct.
Okay, and that has good success?
I mean, when it comes down to it too, is keeping close eyes on those people. So when we identify that they have these kind of issues, it's always something in our back of our minds too, because when they hit a stressor, because they're going to, because it's life, to be able to help coach them through that without using food as the comfort or the tool to help them overcome. So it's using other modalities or options to actually deal with those emotional stresses.
Talk to me about cross-functional specialties. How are you working with those?
So we actually work with our specialties across multiple disciplines. We deal with orthopedic surgeons, we deal with cardiology, we work with hepatology, fertility. Obesity touches so many conditions that it's not unusual to have them reach out to us to see if can you help. And so the referring base is a lot of cross-specialty, but we also have to work with cross-specialty with our bariatric surgeon colleagues as well. And so we help work with them when they have issues that need endoscopic resolution, such as like complications, leaks, and fistulas. But they help us out when we have complications as well. So it's a great dynamic where we think about we both help each other out, and ultimately the patient at the end of the day wins in that case.
All right, so talk to me about how you're educating the patient about the procedure.
It's interesting. The patients come in, I've already done a lot of research on the procedure. So these are predominantly self-referral. So that means they've looked it up. They've done their own homework on it. Whether they're getting accurate information, a lot of it's from social media. Can't always trust what's out there. But they come in informed, and they come in saying, this is what I want. And our job is to make sure that the information they have is correct and that they are appropriate candidates for the surgery or the endoscopic procedure. And so a lot of it is making sure that they understand what the benefits are, what the risks are, and the true expectations for weight loss. And that's when going back in and understanding that I'm giving you a tool. This is a hammer. You have to pick it up and nail the nail. Sarah's laughing because I have the same one-liners all the time, and she's like memorized them. The hammer thing is a big thing because people always say, they invariably compare to their friend that had bariatric surgery.
Oh.
And they're like, they look so great or they did so well. It's like, well, this is a different procedure. This is apples and oranges. And your expectations about what the journey is going to be like will be different. And because we're doing something less invasive that comes at the benefit of less complications, maybe less risk, but you're going to have to work harder for your weight loss. It's going to be something that you're going to have to put in the effort, that this procedure is just a tool. And if you don't put in the effort, you're not going to have maximum outcomes.
Do most come in with the perception that it's the procedure and it's over, and then you have to basically teach them this is just part of the journey and there's all these other things? Is that normal for them to think you're going to hand them essentially a pill to fix it?
People would love a quick fix. I mean, that's what GLP-1s are being perceived as, but it's not that easy. And we do know that if you don't follow up, you're going to have worse outcomes. And we've had patients that have self-paid for procedures. They come see us once for recovery, and after that they've disappeared, and that's not going to lead to optimal success. So we try to get them back and try to have as much engagement. Ideally, we'd have 10 to 14 interactions over a full year period.
Gosh, almost a little bit more than once a month.
Yeah. And that's why having that team is really important, because as a physician doing endoscopy, I can't see a patient, every month typically. So that's where Sarah comes in, and our dietitian and our behavioral psychologist, all of them kind of play a role in those contact points.
So how long is the whole procedure from the first time they come to see you till when they get that procedure?
That's a good question. Depends if they're ready for the procedure, but usually, again, if they're coming in and they're a good candidate It takes about, I would say about 4 weeks or so just for insurance checks, and then making sure they see our dietitian and our GI psychologist. And once they get all the clears from everyone, we can schedule right away typically.
Patients have different expectations if they're self-pay. A lot of times if they're self-pay, they want it as soon as possible. And sometimes we have to pump the brakes a little bit and say, well, let's make sure that you're safe and a good candidate for this. But it's a unique situation because with self-pay, they have the option to travel to other places. And if you don't do it, then they can find someone that will. But we have to hold to our standards in terms of doing evaluations. And there have been plenty of people that have had the financial means to do a procedure. They say, this isn't a good fit, or at least not right now. But if you do elect to choose insurance pre-authorization as a route, it could take longer. We often say 4 to 6 weeks, but typically it may take longer, even up to 3 months. But we've had denials by insurance companies that we've been able to get reversed. So with appeals, which is exciting.
Okay, I sound really ignorant, but I didn't think insurance was paying for this at all.
Yeah. Oh, yeah. So we get it's not great. It's about a 10 to 15% insurance coverage rate, but it can happen. It's worthwhile to doing. And Boston Scientific has built up this patient access support program. So actually, every patient we see in clinic, we send their information to that PASP program, and they will try to get pre-authorization. And if they get denials, they'll actually handle the appeals. And we've had people get overturned, which is great.
That's awesome.
Yeah, and I think, Sarah, I think, we have patients from Medicare and Medicaid.
Medicaid is more
Medicaid
so,
well.
yeah, we have a lot of Medicaid.
So we typically think this is something like commercial insurance coverage, but we've had Medicaid and Medicare coverage too.
What % of your patients do you think are cash pay, and what % are trying to work through insurance?
Well, working through insurance is one thing, right? So, even if people are self-pay, they usually try to seek a pre-authorization, because if I didn't have to spend that money and my insurance company would cover it, I would pursue that option.
Yeah.
And we advise them to at least pursue that or investigate that. But I would still say 80% still end up being self-pay. And so it's kind of, when you talk about healthcare equity, and right now it's not an equitable market for that because of that cost burden that comes with it. And so when we heard that we have a new CPT code for covering this, it's generated a lot of excitement, because the hope is that by developing insurance coverage, we'll be able to open this up to more people.
Of course, yes. So I want to know what you were not prepared for before you started building this practice.
Yeah, we focus so much on the technical aspects of the procedure that we knew that you'd have to develop that skill set. What I wasn't ready for was actually part of the program building, which is dealing with the finances behind the scene, as well as the need for marketing and how you market and what's your digital presence and social media. And so the finance part was, in GI or medicine subspecialties, there's almost no procedure that requires self-payment. And so developing the infrastructure to say who's going to take the self-payment, who's going to process that. There's occasionally the patient will pay. We'll do an upper endoscopy during the time, and we'll find a reason not to do the procedure. We have to delay it, like they have inflammation or an ulcer or other condition that says, it's not the right time for an ESG. We'll back out. So then what do you do with that payment? What do you do with how do you cover that EGD? So there's all these things behind the scenes about managing the finances that I was not ready for. And that includes developing a self-pay price, right? And so how do you determine what's a fair price at your institution? There's so many components, like facility fees, device fees, anesthesia fees that come into play. So navigating all the financial stuff behind it was kind of new. And then along that same line with the marketing, most of our patients are learning about this on social media platforms, whether it's Instagram, TikTok. I'm not ready to start dancing on TikTok yet. So that hasn't happened yet, but I've put out Instagram live videos, and so you have to put yourself out there a little bit, but that's how patients are learning it, and it's a little bit of word of mouth. And you look at the most high volume centers across the country, a lot of them have a very strong social media presence.
Oh, I am sure of it, because you could put before and afters, and then they like you and the whole thing.
Absolutely. Before and afters is something that we were not prepared to do. That's not something we routinely do in endoscopy or GI practice, but we've had to implement that into our program and practice and work with marketing to try to develop that content.
Are patients willing, or maybe you cut their faces off, are they willing to show a before and after?
Sarah runs our Facebook group. So we have a private Facebook group for only people that have had procedures. So it's like a safe space. And we've seen a lot of things different posted on there.
Yeah.
Well, that I get. But
Yeah.
do I want my weight loss picture on Instagram or TikTok? Do they allow you to do that?
Some of them are pretty open to it. I mean, again, they're just so proud of how far they've come and what they've accomplished. So there's a few out there who definitely be like, yes.
Obviously, if anyone is involved, before we post anything, it'd be, with their permission, and they have to sign off on some
Yes.
stuff. And I think not everyone does want to post that information, but some do. And again, I think Sarah said it right. People are really proud when they have this.
All right, I'm going to shift over to you, Sarah.
Oh, no.
So I want to know how you're helping these patients develop sustainable eating and exercise habits after the procedure.
I mean, it comes to a lot of work even beforehand too, because we want to make sure they're kind of set up for success. So I think it's important that we have these conversations starting from the beginning. A lot of them come in already having tried multiple diets or have tried, different like Orange Theory or HIIT training, stuff like that. So it's kind of already set up, but at the same time, we gotta gear it to what they need, the individual needs, as well as like kind of what the research shows with like high protein, complex carbs, and kind of re-educating, like Dr. Chapman said, like, what is a good quality protein? What's better with the bioavailability when it comes to protein shakes? What's actually taste good? And they really want us to kind of help them and guide them along the way.
Do they resist wanting to start working out? Or are they open to that after?
Depends on the person.
Yeah.
Yeah. But a lot of them are really, really excited, which sometimes we have to be like, okay, we got to calm down, because they're like, I'm trying to walk, they started walking a lap after the procedure and they couldn't even make a full lap around their block and they had to have someone pick them up. So it's like, your energy's not there. The caloric intake's low. We just got to take it easy. So yeah.
How soon after a procedure would they be able to go and work out and have full energy?
Usually around 4 weeks when they actually start having more solid foods. So 4 to 6 weeks, we start engaging into the exercise regimen. So resistant bands, we always kind of push a lot more weight training or strength training at first, because again, the lean body mass we want to preserve.
Yes. So what do you see as the biggest challenges in the industry?
Coverage is number one, like, as you guys were talking about earlier. And then also just education about what the procedure is and expectations. I think that's something that we really have to work and talk with the patient through, because what to expect, especially again in the age of the GLP-1s, they're expecting things right now. It's like, no, it's going to be slow and steady, but that's the way we want it.
So after the procedure, how do you monitor them for weight gain? And if they start gaining weight, what do you do?
That's where the Facebook group comes into play. We have a support group too we also run, and as well as like post-procedure follow-ups. But there's all these different avenues we try to keep in contact with the patient, so they're always kind of in touch with us. So we kind of know when things, when they start to kind of plateau or they start to regain the weight back.
Yeah, I mean, that's where the follow-ups are so key, and making sure that we try to catch them because life stressors are going to happen, and a lot of people, food is their comfort when they deal with life stressors. Or
Everyone.
Yeah, exactly. and or if you travel and they're living out of a hotel, it's hard to adhere to the diet that you want to do, or do the exercise regimen you want to do. And so sometimes we will try different dietary measures to say, try intermittent fasting, or we try maybe resetting the diet, going back to liquid diet for a short term to kind of help get them motivated again. And we find that reset sometimes helps with people too.
100%. And when old habits creep back into like the alcohol intake or the holidays, kind of gauging what they've kind of been doing, which can lead to the weight regain.
And there's so much like family and emotional sometimes too. Remember, just during Thanksgiving, we had so many times that patients' families would be pushing food on them.
Yeah.
And so they'd
saboteurs.
be yeah,
it's
exactly.
a real thing. It's a
is,
real
right?
thing.
Yeah, and I mean, and a lot of times food is the love language, right? And so and if you don't eat, they ask like, do you not like it? And so it becomes kind of a social aspect as well. And so that was a big, when we had our social support group meeting for around Thanksgiving, Christmas, a lot of us talking about how to deal with food pushers at holidays, because a lot of times that's what they struggle with.
What's the answer to that?
Hold something in your hand.
Seriously?
Yeah. So we said
kind of like if you're not drinking, having
Yeah.
a glass of like a carbonated drink, so it looks like you're drinking and nobody asks. Same
exactly.
idea?
Yeah. So we said put some food on the plate, and then so they won't come up to you and ask, do you want to try this? It's like, oh, I already have this. Thanks. So we literally came up with talking points. So when they're in their family settings, like what we can talk through to help avoid, for them to.
And we're not the brilliant ones that came up with that. That was actually one of the patients in the support group that actually said that was her strategy.
Mm-hmm.
And we're like, wow, that's a great strategy.
No, it is.
And that's, I think, the power of having this support group, and people can learn from each other, and we learn from our patients and vice versa. It's great.
Yeah.
So you were talking about the weight loss. I am curious, what % of people do you gain? Like after a year, after 2 years? Is there data on that?
The data on weight regain after an ESG is not very strong. And so I think in our clinical practice, you still probably see about 10%, 15% that, really struggle afterwards. Some of the data has looked at repeat ESG or how many often that was. As I mentioned earlier, Reem Shariah put out some work with 5-year outcomes showing durable weight loss out to that time, but she did have a rate of weight revision procedures or conversion to surgery as well. And so, but they were very low, like single-digit percentages in that study. But it's something that this is a lifelong battle. And no matter what you choose as the option for losing weight, if you don't have the follow-up or stick with make these behaviors habit, you're not going to have a good long-term outcome.
Yeah.
And so it's about really changing your life. And I tell people when they're in the room with us and we're thinking about ESG, I want this to be a branch point in your life where you look back, you're like, I could have gone left, I could have gone right. I chose to go right, and then I moved on and I actually changed my life from that point. So we hope it's like as foundational as getting married or having kids. We try to preach that. It doesn't always work, but we want it to be a branch point in their life where hopefully they dedicate themselves to their health. And there's no greater investment than your own health.
No, that's good. All right, Sarah, I want to know what your specific role is in ensuring that the patients are physically and emotionally prepared before they do this procedure.
Yeah, so I usually see a lot of the patients in the initial clinic visit, so it's kind of gauging their readiness to kind of go into the ESG is kind of the big part of the initial clinic visit. So kind of seeing, again, what kind of diets they tried in the past, how they can handle the procedure and the post-procedure diet, I think is really crucial. So again, seeing like what they're eating and getting that dietary recall can really kind of help us gauge like, oh, we need some work before we're going through with this procedure.
And then how are you helping them set realistic goals?
A lot with the motivational interviewing techniques we use, like again, open-ended questions and stuff, trying to gauge like, again, when they're ready, their willingness and readiness to have this procedure, and then what changes they kind of have planned or put in place, as well as, again, the SMART goals, as you probably have heard before, like be very specific and have it measurable. I think that's something really important because they have these broad, like I'm going to lose like 100 pounds. I'm like, okay, that's not realistic. Let's get back to like, let's see what you are in 3 months and in 6 months. So we have these short-term goals that they can reach, and then they feel proud when they get to that. Because if they say 100 pounds over a year, it's like if they don't hit it, it's going to be, they feel defeated.
It's devastating for people when they have inappropriate goals and they don't achieve it, right? Because there are a lot of times these people, as Sarah mentioned, this isn't the first thing they've tried, and it's been a challenge. And we all know people that have had yo-yos. They go up and they go down and they go back up, and it's emotionally taxing. And they're like, I took the next step of having a procedure, and when they don't do as well as they want or they don't meet their own expectations, it could be a hard conversation to have.
Yes. All right, so I want to talk to you guys about the relationship y'all have.
Yeah.
Clearly, y'all been working together a long time. He stole you away and made you come back working with him. So talk to me about
I didn't make her. She volunteered. I think there was some there's some benefit to come. Yeah.
So how do you develop this working relationship? So for maybe there's another physician listening. How do you develop a relationship that works like this?
I mean, our approach to patient care is very similar, which I think is good. So it makes it easier to work with him because I know like what his expectations are. And I also agree with like how he takes care of the patients and, cares about the outcomes.
I think, we're not procedure driven, we're patient driven. And both of us have the same goals in mind, where it's about making sure we take care of people and we respect it and honor it as a privilege to do so. And so once you're aligned on that, you can really focus in on working together and having that alignment to outcomes. And I do think, we've been working together so long, and we spend time in the clinic together. So she's seen how I interact with patients, and it took time. I mean, it takes time to develop the trust and the relationship. But I know that if Sarah has concerns about a patient, I have to take that seriously. And if someone with ESG, it's interesting because patients will have pain after the procedure, and sometimes it could be benign, like dietary indiscretions, but other times it could be real. And I could tell you, Sarah's saved my butt several times because she's taken some of these complaints real. And Sarah, you could tell the patient about that, with the x-ray and what we found.
Which X-ray?
Sarah loves X-rays, so if you come into our clinic, you get an X-ray because everyone's constipated. You can find that in X-rays. But the lady that she came with us after an ESG, 8 months out.
Oh, 8 months, yeah.
And now you can go. I teed it up for you.
Thanks.
Yeah.
And so after, again, had the ESG, so she has this vague abdominal pain and some bloating. She keeps on saying us, you always think of like, are you eating too much protein, not getting enough fiber, like what's kind of going on, not enough calories. So after she kind of talked a little bit more through it, I got an X-ray on her. And then on the X-ray, it showed like some extrinsic compression on the colon, or like it just looked weird. So I ended up having Dr. Chapman look at it, and we decided together, like, let's get a CT and see what's going on. And she ended up having a 29 centimeter ovarian mass. Yeah. Luckily benign, but yeah, pretty large.
Whoa.
So this patient that saw her PCP 2 weeks before seeing us in clinic, and they didn't do anything about it. And we're dealing with her weight issues, and she's like, I can't lose weight. And we're like, what is going on? And then we get the X-ray, and it's this giant haziness in the center of her abdomen. And we're like, well, that doesn't look normal. So we ended up getting a CAT scan and showed this giant ovarian mass. And so understanding where the patient is. So like a lot of times patients will have abdominal pain in the first week or so because it's just accommodated from the sutures you put in. But 8 months out, that should be a red flag that something else potentially is going on. And so I think we were able to find something that I think would have been otherwise overlooked and could have gotten a much bigger problem.
Why do you think the PCP ignored that?
Oh, she left.
She's gone. She's a goner.
She was close to retirement. It was the patient's excuse of why she didn't catch it. But yeah,
I think abdominal pain's vague too, and that's another thing when we're GI by training, and so if people have abdominal pain, they're like, well, they're seeing a GI. So once you have a endoscopic procedure with us, you're kind of like part of the family, and now we take care. So if you come in and you haven't had a screening colonoscopy, don't worry, Sarah will make sure that you get a screening colonoscopy as well.
Colorectal awareness.
Yeah, colorectal colon cancer screening. Yeah, so I think we're kind of, we feel responsibility for the patients when they come in and they put the faith in us and having a endoscopic procedure that we're kind of their GI team. And so I think we deal with the successes, but also the high highs and the low lows too.
So how do you guys ensure, I mean, it seems kind of obvious, but how do you ensure such good communication? Do you guys debrief at the end of every day? Are you just texting during the day?
I harass him.
You harass him?
When he doesn't respond.
Well, she has an Android and I have an iPhone, so I know. Can you believe that?
All her bubbles are green?
She's a green bubbler.
It's so mean when people do that to us.
I know, and I can't send, replies the way I want, and so it's tough.
Sarah.
It's really been, it's like, if there's one drawback working with Sarah, it's the green bubbles.
All of you guys, anybody watching on YouTube, can you just comment that she needs to get an iPhone so the bubbles are no longer
Have
green?
a brush pay for it, and I'll be more than happy to get
Actually, you're probably all the YouTube people like, do the Google instead.
That's probably true. Okay.
Yeah. But no, I mean, we communicate, we text all the time. She does an excellent job of, if a patient's having an issue, she'll bring him into clinic or in the endoscopy suite and will come find me and drag me out of an endoscopy procedure. And so you have to come evaluate this patient. And so, as I think you said earlier, she's front of house and I'm back of house. Like if you watch The Bear, she's in the front and it's all nice and clean in the front. And then it's chaotic in the back in the endoscopy suite. So she does a good job being front of house.
And then how do you guys divide all the responsibilities?
So it'll be interesting to get her opinion because I think she does most of the responsibilities. So anytime you're building an endobariatric program, you need to have a multidisciplinary team, right? And that includes dietitians, psychologists who've addressed that. But it also includes patient navigation, who's going to process your insurance, who's going to make sure that things are moving along, intake, all that stuff. And sometimes people have to wear multiple hats in that program, and Sarah wears multiple hats for us, where it really is kind of also my de facto patient navigator and insurance process, following up the claim, the process in this where they are in that approval. So I would say I'm very good to do procedures, and Sarah's very good at
the rest.
Everything else.
There's times that she's good cop and I'm bad cop, and there's times I'm bad cop and she's good cop, because sometimes patients need a little motivation in different ways to kind of get back on the wagon, and we play off each other quite like that. So I'd like to say I'm Batman and she's Robin, but she's kind of like, that's probably not. She's probably Wonder Woman too, and she's got her lasso of truth, and it's going to get really nerdy very fast, when we start talking about comic book people. But she does a lot for her program, and so she's probably not Robin. That's probably not fair. She's more of a Wonder Woman.
It's fun working with somebody that there's like so much mutual respect. I love that.
Yeah, no, that comes over time and years, right? And it's been great, and it's really nice to see her blossom. And she's now lead APP, Rush University, so she oversees all the GI APPs. And so seeing her blossom into her leadership roles has been fun too.
Oh, that's awesome.
Yeah.
So I don't know if you guys want to finish on maybe a really great case. Like, I'd love to hear another patient story.
Which one do you want to do?
One really does come to mind. So we had a 38-year-old woman who was dealing with class 2 obesity. So her BMI was about 38. And she had fatty liver disease or non-alcoholic steatohepatitis. They call it something different now, but, fatty liver disease. And she had inflammation. So her liver enzymes were elevated, suggestive that she did have inflammation of the liver at age 38. And we know that if that continues to happen, you're going to likely or have risk to progress to cirrhosis. So it's a very serious, under-recognized condition that we're seeing more and more. So she came to us for weight loss, and we ended up putting a Orbera intragastric balloon in her, and she ended up losing about 15 kilograms and dropped her BMI by like 6 points. We checked labs, and her LFTs completely resolved.
Oh, wow.
So all the inflammation went away. So we knew that by losing this weight, she would have resolution of that inflammation, which was great in and of itself. So we removed the balloon. The balloons only stay implanted for 6 months, and then you have to take them out. And she's kind of going the wrong way. But what we found out was the reason that she actually was starting to gain weight is because she became pregnant.
No.
Yeah, and so she became pregnant, and that was causing her weight regain.
Oh my gosh, that's so awesome.
It was fantastic. And what we then, what we discovered is that she had tried IVF 4 times beforehand.
Oh my gosh.
3 times that it didn't work, it didn't implant. The 4th time where it actually did implant, she miscarried. And in Illinois, you only get 4 rounds of covered insurance for IVF. So with this intervention that we did, and we kind of reversed the inflammation in her body, she was able to have a natural, spontaneous pregnancy. And so to think about what we do, all the polyps we remove, all the stones we remove, all the stents we put in, I don't think there's anything in our practice that has more impact on patients than what I do in the endobariatric procedures. And I think when I hang up the scope and I'm done scoping, I'll probably look back and say those endobariatric patients would have the most profound impact, and what I've done for people will come back to these procedures. And she actually named her baby Gemma Christine, and the Christine was for me, for Chris Chapman.
No.
Because she felt like she would otherwise not have had that child. And that's not the only time that that's happened. It's been 2 or 3 that I've had.
Okay, that's amazing. That was a really good way to finish.
Yeah.
And thank you guys for coming on. This has been awesome.
All right.
Thank you for having
Thank
us.
you so much. Yeah.
Thanks for listening to this episode of EndoCast. Please subscribe to the podcast and follow Boston Scientific Endoscopy on our Twitter, YouTube, and LinkedIn feeds. You can also visit our virtual education platform, EduCare. That's edukare.bostonscientific.com and choose gastroenterology. The site features over 180 resources, including physician-led educational videos, lectures, case studies, device training videos, procedural tips, and techniques. Thanks for listening. EndoCast listeners, an important disclaimer. These materials are intended to describe common clinical considerations and procedural steps for the use of reference technologies, but may not be appropriate for every case or patient. Decisions surrounding patient care depend on the physician's professional judgment in consideration of all available information for the individual case. Boston Scientific does not promote or encourage the use of its devices outside of their approved labeling. Case studies are not necessarily representative of clinical outcomes in all cases, as individual results may vary. Thank you.